Good afternoon to all. So this is your lecture on somatoform disorder and dissociative conversion disorder. The aims and objectives are to define somatoform and dissociative disorder, the historical approaches, review information regarding prevalence, onset and course, discuss current etiological findings and clinical features of all, and outlining the treatment approaches. So first we will go through the terms, somatoform, what is dissociative and what is conversion. Somatoform disorders involves the presentation of medically unexplained symptoms, which means the symptoms are there but cannot be explained by virtue of physical examination and lab investigations. Dissociative disorder involves the loss of normal integration of the identity of self, the memory of the person, perception and the level of consciousness or disturbance of consciousness. So dissociation is a mechanism whereby one part of mental functioning is split from the rest, which is memory, consciousness, perception and identity of the person. As per the ICD-10, the dissociation is it shares the common theme of dissociation and conversion, which is a partial or incomplete loss of normal integration between memories of the past, awareness of the identity of self, immediate sensations, which are bodily sensations, and control of the bodily movements. The historical approaches of somatoform disorder. In the ancient term, hysteria referred to non-fatal malady of women that included different types of bodily symptoms. So it used to occur in females mainly. So it is referred to hysteria, which the term came from the word hyster. Hyster means uterus. So it is correlated with the dysfunctions of women. And the most classic cases of hysteria is NAO, which was written by Joseph Breuer and Sigmund Freud. Regarding NAO, she was a young Viennese woman who reported multiple somatic symptoms which were suggested to be associated with psychological trauma of her father's illness and death. So there is a stressor and trauma which resulted into the somatic symptoms. The term conversion signifies the transformation of psychological material into somatic symptoms. The psychological happening or trauma can lead to somatic symptoms. This can be understood by a simple example. When a school going child around the age of in the adolescence period, they used to complain regarding the abdominal pain and like headache in morning when the school time is approaches, to avoid the stressor of academia in the school. So that stressor of academics is converted into the somatic symptom, which is abdominal pain. So this is a simple example. The treatment of NAO was the first described case of psychoanalysis, which was postulated by Sigmund Freud and also known as talking cure or talk therapy. Freud theorized that hysteria was the result of consciously unacceptable sexual fantasies from childhood. Sigmund Freud also has given theory of libido, which is known as libidinal theory, and which is related to the psychosexual development of the child, and the happenings were correlated with the development of child is correlated with the development of sexual characteristic over the period of time. So this theory in detail you can learn in the another lecture video in our channel in detail. So this is the overview of somatoform disorder. it appears to be physical or medical but are due to psychological factors. The symptoms may mimic a physical problem or a medical problem, but underlying there is a psychological problem. By means of lab investigations and physical examination, nothing significant will be found. Psychological disorders masquerading as physical problem. The meaning is same. People with these disorders do not consciously want or purposely produce their symptoms. No intentional or not these are not intentional or under voluntary control. This doesn't mean that the person is creating those symptoms voluntarily. This is happening because of the underlying psychological cause or psychological trauma. This is not in the voluntary control of that person. तो कभी भी इस डिसऑर्डर के पेशेंट्स अगर मिलते हैं तो उनको कभी ये ना कहें कि इनको कुछ नहीं हुआ है, ये ठीक है, या ये नौटंकी कर रहे हैं या मक्कारी कर रहे हैं या बहाना बना रहे हैं. For medicine, for physiotherapy, and for other branches like anesthesia, there is no impairment seen because of these presentation, but for psychiatrists, these are the disorder and have to be referred and treated. The conflict and the trauma should be addressed and relieved. People with these disorders believe their problems are genuinely medical. They believe that they have medical illness because that psychodynamics, they cannot understand why these somatic symptoms are appearing or happening. These symptoms are not due to effects of any kind of substance or alcohol, not due to another mental disorder. Symptoms causes significant distress or impairment in functioning. These disorders are also denoted as functional disorder or medically unexplained symptoms. Now, how the patient presents? They can present as having symptoms of musculoskeletal system like low back pain, generalized malaise or fatigue like chronic fatigue or fibromyalgia, GI symptoms like abdominal pain, bloating, or having diarrhea or other symptoms, gynecological symptoms, heavy or painful periods, neurological symptoms such as pseudo seizures known as dissociative, convulsion, regional pain presentation like atypical chest pain or headaches. The somatoform disorders are classified in ICD-10 as follows. The chapter is F45 for somatoform disorder. Subclassification as somatization disorder, hypochondriacal disorder, somatoform autonomic dysfunction, and further subclassified as per the system involved like cardiovascular system, GI system, respiratory system, genitourinary system, and other organ. Another classification is persistent somatoform pain disorder. In epidemiology, these are the medically unexplained physical symptoms which are common in somatoform disorder, and formal clinical somatoform disorder are rare in the general community, but it is more prevalent among those who are into the medical setups, those who are the high utilizer of health services. Anxiety and depression are common in people with unexplained physical symptoms and those with the somatoform disorder. So comorbid anxiety depression can be seen. Somatoform disorder are more common among women. In etiology, as we know that all of the disorder has some kind of biopsychosocial factors. So for somatoform disorder, the biological factors which are seen are underactivity of hypopituitary adrenal axis, which is known as HP axis, and can be the explanation of fatigue. Neurobiological models focus on how sensory and motor information is processed. So to understand simply, We got a stimuli like touch, pain, vibration. So there is a threshold for the brain or neuronal mechanism which has some kind of threshold to perceive that sensation. Uh, to perceive that sensation. If the threshold is reduced, then a smaller amount of stimuli can also create that sensation or perception of sensations. So there is neural gates mechanism theory of neural gates. The neural gates in the spinal cord can be opened or closed, determining the amount of pain the individual experiences. The more the activity in the pain fibers, more gates are opened. More activity in peripheral fibers regarding stimuli around the body, more gates are closed. So message from brain can be open or the closed gates. This is theory or hypothesis which is not proven true. Another biological factor is to experience somatic symptoms as intense, noxious or disturbing, which has three elements: the hypervigilance, selecting out some sensations, intensification by cognition and affect, making them more alarming. So what these theories want to say that the normal sensations of the body, like uh, intestinal movements, are perceived as exaggerated movements of intestine and perceived as a painful condition, bloating or other symptoms of abdomen. Regarding the trauma and personality factors, patients with somatoform disorders are more likely to have experienced adverse event in childhood. One theory proposed that memory of the early trauma is contained in the emotions, reflex actions, and bodily sensations. So these childhood trauma or childhood mishappenings are turned into the bodily sensation in adulthood. Negative events in childhood may also give rise to personality characteristics that predispose the person to somatoform disorder. Childhood trauma leads to a certain kind of personality, and that personality is vulnerable to acquire the somatoform disorder. People with somatoform disorder have higher rates of alexithymia, means difficulty experiencing or expressing emotions. Failing to identify and express emotional distress may lead to increased physiological arousal. Another theory is cognitive and behavioral factors. So you have learnt about the cognitive and behavioral theory in your psychology class of learning theories. So what it says that cycle of somatosensory amplification leads to tendency to experience somatic sensation as intense and distressing. So you can see in the figure there is lots of interchangeable expressions of anxiety, depression, stress, and that leads to alexithymia, and there is somatosensory amplification which leads to somatic symptoms. Now come to the individual disorder. Somatoform disorder has many condition. One is somatization disorder. The main feature of somatization disorder is repeated presentation of physical symptoms. Physical symptoms are presented repeatedly together with persistent request for medical investigation. After reassurance, they not get relieved and they want repeated investigations which claims to be normal, and in spite of repeated negative findings and reassurance, the symptoms has no physical basis. Onset and continuation of symptoms bear a close relationship with unpleasant life event or with difficulties or conflict. There may be unpleasant life event in the past or in the childhood. Maybe the person is having difficulties or conflicts in the current situation. and the patient usually attempt to discuss these conflicts and life events. They do not relate those life events with the current symptoms. Often a degree of attention-seeking behavior is present, also known as histrionic behavior, in which the person used to try to get the more attention of others towards him or her. Persistent refusal to accept the advice or reassurance of several doctors that there is no physical explanation for the symptoms. Despite of that, these persons are in trouble or having problem that should be resolved. Second is hypochondriacal disorder. There is persistent belief in presence of at least one serious physical illness. In somatization disorder, there were signs and symptoms, but there is a name of a disease, disorder or syndrome with which the person present. In this condition, after repeated investigation and examination, have identified no adequate physical explanation, which is the common feature of these stress-related disorders or somatoform disorders. Persistent refusal to accept the advice and reassurance of several different doctors that there is no physical illness or abnormality underlying the symptoms. What underlying psychological factors are there? Then is the somatoform autonomic dysfunction, which may presented with various features of systems like cardiovascular system. So cardiovascular system, also called as cardiac neurosis, GI symptoms called as gastric neurosis or nervous diarrhea. If respiratory system is involved, is called as psychogenic hyperventilation and psychogenic hiccups, which are common presentations. The symptoms are usually of two types, and neither of which indicates a physical disorder of an organ or system concern. The first type characterized by complaints based upon objective signs of autonomic arousal. Autonomic nervous system you must know, and the symptoms of autonomic hyperactivity you must be knowing. So they present with autonomic arousal. The second type is more idiosyncratic, subjective and non-specific symptoms such as sensation of fleeting aches and pains, burning sensations, heaviness in chest, head or bodily parts, tightness and sensation of being bloated or distended. These are referred by the patient to specific organ and system. So specific system is involved in this somatoform autonomic system. The person will confine to either to the cardiovascular system or to the GI system like upper GI or lower GI or to the respiratory system. Persistent somatoform pain disorder. The predominant complaint is of persistent, severe and distressing pain which cannot be explained fully by a physiological process or a physical disorder. Pain occurs in association with emotional conflict or psychosocial problems that are sufficient to allow the conclusion that they are main causative influence for the pain. The result is usually marked increase in support and attention, either personal or medical. So attention seeking behavior is also a central point for these disorders, which are secondary to their primary problems. Pain presumed to be of psychogenic origin occurring during the course of depressive disorder or schizophrenia should not be included here. Somatic symptoms may also be present in case of depression and other psychiatric problems that should not be included here, and neurological conditions also like tension type headache and migraine. The differential diagnosis for somatoform disorders are those affecting multiple organs like systemic lupus erythematosus, sarcoidosis, lymphomas, uh, pain disorder due to physical problems, depressive disorder, schizophrenia, delusional disorder, factitious disorder and malingering. Factitious disorder means feigning the illness for some psychological gain, and malingering is for other gains. The treatment requires a strong doctor-patient relationship, and it is the key to getting help with somatoform disorder. And it is advisable that a single health care provider with experience managing somatoform disorder can help cut down on unnecessary tests and treatments. So there is a doctor-patient good relationship is required, and it is advisable that one doctor, one psychiatrist or psychologist should treat these person. Multiple therapists cannot help these problems. The focus of treatment is on improving daily functioning, not on the managing symptoms. Symptoms are there for the patient, the symptoms are there, but these are not because of directly physiological problems. Stress reduction is often an important part to get better. Counseling for family and friends may also helpful when there is a conflicts between the family members and with the others, that should be resolved. CBT may help relieve symptoms associated with somatoform disorder, and CBT involves uh, correcting the distorted thoughts, unrealistic beliefs, behaviors that feed the anxiety. You must be recollecting the lecture of cognitive behavior therapy in psychology. What is the cycle behind the cognitive behavior therapy and cognitive behavior theories? Now coming to the dissociative disorder or conversion disorder. These are subclassified as dissociative amnesia, fugue, stupor, trance and possession disorder, motor disorder, convulsions, anesthesia and sensory loss. So now learn about the dissociation first. Dissociation is a disconnection between a person's sensory experience, thought, sense of self or personal history. Dissociation is also known as a defense mechanism in which conflicting impulses are kept apart or threatening ideas and feelings are separated from rest of the psyche. So patient get dissociated from one of the aspect of himself. Someone with dissociation might feel a sense of unreality and lose their connection to time, place and identity. Several factors can play a role in the development of dissociation, and the potential causes are trauma, drug use and other medical conditions can also produce dissociation. But we will talk about the dissociative disorder which has purely psychological underpinnings. So there are two terms, dissociation and conversion. So what is dissociation and what is conversion? So conversion is conventionally applied to somatic symptoms, whereas symptoms is psychological rather than physical is regarded as dissociation. There are two kinds of presentation in this disorder. Uh, One seems to be uh, having involvement of bodily functioning like motor symptoms, like sensory symptoms, and others are like amnesia and stupor. So what is visible by eyes are conversion. Patient fell down, patient is in stuporous condition, patient is having pseudo seizures. These are visible. So these are considered as conversion. And the thing which cannot visualize like headache, amnesias and anesthesias, these are dissociation. Epidemiology is not well established. Prevalence of dissociative amnesia is controversial, but recent estimation of 1.8% in a community sample in a study found dissociative identity disorder 1% in community, but much higher in clinical samples are seen. Etiology. The dissociative disorders believed to be stress related. So some kind of stress is always behind this presentation. In psychological mechanisms, one can have distorted perceptual factors, how the person perceives for himself, herself, or surroundings, the belief system of the person, the mood swing of the person, and the personality factor, the ego defense mechanism of the person, and the coping style. How efficient the person is able to cope with the stress. So we now coming to the individual disorder. In dissociative amnesia, what happens is uh, it's a type of dissociative disorder characterized by inability to recall important personal information. मुझे कुछ याद नहीं आ रहा है, but there is no neurological basis of that. It is usually caused by trauma or stress, and people may lose memories relating to distressing or upsetting events. And these amnesias are more centered towards the difficult situations or conflicts the person is having in their life. They try to suppress their memory. Dissociative fugue is a rare psychiatric phenomenon characterized by reversible amnesia for one's identity in conjunction with unexpected wandering or travel. So these people totally get detached from their identity and themselves presents as a total different identity, which have separate emotions, separate personality traits, and separate uh, a total of separate identity. And these people may found wandering or traveling in different situations. If you want to understand dissociative fugue, there is a movie called as Cybil, Cybil. This was a true story about a female who had this dissociative fugue or multiple identity disorder. There is a movie also in which a person, a characteristic, suddenly turns into a different kind of personality. It's a South movie. That is not the true presentation, but you can relate with that movie. How a personality can change into another. एक टाइम पर वो बिल्कुल एकदम सीधा साधा सा होता है, then he becomes different kind of aggressive personality suddenly. Stupor, you all know, stuporous condition is a condition where consciousness is lost. But in dissociative stupor, it's a rare form of stupor characterized by severe reduction or complete absence of motor, behavioral, and affective response to the environment. There is absence of these responses, but actually the person is not unconscious. कभी कभी या आपने कहीं देखा होगा या सुना होगा आपके आस पड़ोस में कुछ औरतें बेहोश हो जाती हैं। इसके ऊपर वही है, स्ट्रेस आया, बेहोश हो गए, हाथ पैर छूट गए, है ना? लेकिन एक्चुअल लॉस ऑफ कॉन्शियसनेस इज नॉट देयर. Trance and possession disorder characterized by a state of temporary marked alteration in state of consciousness without replacement by an with a replacement by an alternate identity. Possession is defined as an episode of alteration in state of consciousness with the replacement of customary sense of personal identity by a new identity. In the words, it seems to be complicated, but in simpler form you can understand. जब किसी के अंदर माता आ जाती है, that is trance and possession disorder. The someone is possessed by a new identity. So this is also kind of dissociative disorder, and behind this phenomena there is a certain kind of stress is there. And again, when such thing happens repeatedly, and the person started getting attention of the other persons. So to get to attention seeking behavior को sustain करने के लिए they used to repeat these kind of behaviors. Similarly, motor disorder, the motor dysfunctions are there, like loss of ability to perform bodily movements. Motor symptoms are there, but there is no uh, biological basis of these motor symptoms, like achynesias, aphonia, apraxia, ataxia. The person present with these type of problem, but actually you will find uh, technically there is no biological basis of these ataxia, apraxia, aphonia, and the symptoms are fleeting and patchy in presentation. Dissociative convulsion is also known as psychogenic non-epileptic seizures or pseudo seizures. The person present with mimicking motor symptoms of a seizure activity, and but not other associated symptoms which are actually due to uncontrolled firing of neurons, like clenching of teeth, tongue biting, incontinence, injury due to fall. These phenomena are not present in pseudo seizures. Similarly, anesthesia and sensory loss, the person may present with some sort of loss of sensation and kind of anesthesia, but it is not following the typical presentation in concurrence with the dermatome of that neuronal supply. Person will say that I am having loss of sensation in this area, but you will find that it is not matching with the dermatome. You know about the dermatome? What are the dermatomes? You must be knowing as a physiotherapist, no? Now, treatment. In dissociative disorder, the treatment can be cognitive behavior therapy, hypnotherapy. If there are conflicts, then family therapy can be done. If there is conflict between family members, physical therapies can also help. In case of the person is having overlaying depression and or anxiety, medications can also help. If person is having insomnia, the medications can help. Biofeedback is an alternative medicine approach that teaches people to change the way of their body functions. It's a kind of a mind-body therapy that may improve the physical and mental health in case of dissociative or conversion disorders. Now, in the summary, we have learned about the somatoform disorder and conversion or dissociative disorder. In somatoform disorder, by and large, there is persistent physical complaints without any identifiable medical cause. Pain, fatigue, or other bodily symptoms that interfere with daily life. Excessive thought, feelings, or behavior related to the symptoms, such as frequent health-related anxiety, disproportionate worry about the severity of symptoms, and spending excessive time or energy addressing health concerns. So somatoform disorder is more related with the sign and symptoms, and while conversion disorder is more related to the presentation of some kind of deficiency in uh, physical functioning. So there is sudden physical symptoms that suggest a neurological issue or a medical issue but cannot be explained, like paralysis, blindness, speech problem, pseudo seizures. Symptoms often appear after a stressful or traumatic event and are not consciously created by the individual. This is an important point. These symptoms are not consciously created by the individual. So don't send back these patients to the home. Send the patient to a psychologist or a psychiatrist. Thank you. Good morning to all. So in the series of neurotic and stress related disorder, today we will covering other neurotic disorders. Other neurotic disorders are neurasthenia, depersonalization, derealization syndrome. So in ICD-10 classification, in other neurotic disorders, there is a chapter F48 which consists of neurasthenia and depersonalization and derealization syndrome. Let's begin with the neurasthenia. Neurasthenia includes fatigue syndrome, which is previously known as fatigue syndrome, and it excludes asthenia, burnout, malaise and fatigue, post-viral fatigue syndrome, and psychasthenia. It is also known as chronic fatigue syndrome. In IC10, it's a ill-defined condition of unknown etiology. Regarding the epidemiology, the precise rate of incidence and prevalence is not well known, and estimates suggest that incidence of between 0.007% and 2.8% within the general adult population. This condition primarily affects young adults, specifically those aged between 20 to 40. It can occur in children and teenagers. It does so at a lesser frequency. Women are at least twice as likely to be impacted more than men. The exact cause of disorder remains unknown. Etiology, the diagnosis can only be confirmed after excluding all other medical and psychiatric reasons for chronic fatigue. So this is a diagnosis of exclusion. No specific signs or tests found that definitely diagnose this condition. Attempts had been made to link the Epstein-Barr virus, but Epstein-Barr virus infection shows distinct antibodies and atypical lymphocytosis, which are not present in neurasthenia. Tests for other viral pathogens like enterovirus, herpes virus, retroviruses have yielded negative results in the studies regarding association with neurasthenia. Some researchers found that non-specific immune abnormalities in individuals with neurasthenia have been found, such as diminished proliferation response of peripheral blood lymphocytes. However, these responses are similar to those found in certain patients with major depression. So this is also a non-specific finding. Numerous studies indicated a disturbance in HPA axis known as hypothalamic pituitary adrenal axis and accompanied by mild hypercortisolism. Due to this, external cortisol has been administered to alleviate fatigue, although the outcomes have been mixed. Some patients shown improvement and some not. Investigations are currently exploring cytokines like interferon alpha and interleukin 6 known as IL-6 as a potential contributing factors. Increased level have been detected in brains of certain patients. MRI studies have revealed a reduction in volume of both regional gray and white matter in individuals with neurasthenia. Now coming to the clinical feature to understand what is neurasthenia or chronic fatigue syndrome. There are two main types. In one type, the main feature is complaint of increased fatigue after mental efforts. It is often associated with some decrease in occupational performance or coping efficiency in daily tasks. The mental fatigability is typically described as an unpleasant intrusion or distracting associations or recollections in the mind, difficulty in concentration, and generally inefficient thinking. In other type, the emphasis is on feeling of bodily or physical weakness and exhaustion after only a minimal effort, accompanied by a feeling of muscular aches and pains and inability to relax. So in one type there is a mental fatigue, and another type there are bodily or physical weakness, can be said as physical fatigue. In both types, a variety of other unpleasant physical feelings are also present, such as dizziness, headaches, sense of general instability, worry about decreasing mental and bodily well-being, irritability, anhedonia. Minor degrees of both depression and anxiety are all common but are not fulfilling the criteria of depressive disorder or anxiety disorder. Sleep is often disturbed in initial and middle phase, but hypersomnia may also be prominent or present. Now coming to the diagnostic criteria, there are two diagnostic criteria. One for Center for Disease Control and Prevention. The clinical features are severe unexplained fatigue over 6 months, that is of a new or definite onset that is not due to continuing exertion, not resolved by rest, and functionally impairing. These are the main criteria. And in B criteria, out of 8, 4 must be present. For example, impaired memory or concentration, sore throat, tender lymph nodes, muscle pain, pain in several joints, new pattern of headaches, unrefreshing sleep, post-exertional malaise lasting more than 24 hours. Now look at the ICD-10 criteria. The criteria A is either persistent and distressing complaint of increased fatigue after mental effort, or persistent and distressing complaints of bodily weakness and exhaustion after minimal physical effort. In criteria B, at least 2 of the following should be present, like feeling of muscular aches and pains, dizziness, tension headache, sleep disturbance, inability to relax, irritability, and dyspepsia. Any autonomic or depressive symptom present are not sufficiently persistent and severe to fulfill the criteria for any of the more specific disorders in the classifications, like somatoform disorder, depressive disorder, or anxiety disorder. The differential diagnosis. In many regions, neurasthenia is not commonly recognized as a diagnostic category, rather put in the continuum of depressive disorders. Historically, many cases labeled as neurasthenia would now be classified as depressive or anxiety disorder in newer classifications. However, some cases align more closely with neurasthenia than with any other neurotic condition, and these instances appear to be more prevalent in certain cultures. So this neurasthenia is also found to be culture specific, and it more aligns with the culture bound syndromes. When considering neurasthenia as a diagnosis, it is important to first exclude any depressive or anxiety disorder. Key feature of this syndrome, unlike somatoform disorder, which primarily involve physical complaints and concern about the illness. If neurasthenic symptoms arise following a physical illness like influenza, viral hepatitis, mononucleosis, it is essential to document that initial diagnosis as well. Now come to the depersonalization and derealization syndrome. It is a condition where individual reports that their mental process, physical sensations, and or environment feel are altered, leading to sense of unreality, distance, or automation from themselves or from the environment. People may sense that they are not in control of their thought, imagination, or memories, but this is not amounting to delusion of control. So they are not in control of their thought, imagination, or memories, that their actions and behavior do not feel like their own, that their body appears lifeless, disconnected, and unusual. Such a feeling can be found in delusion, like delusion of control or delusion of influence, but this is not pertaining to delusional thinking. And that their surrounding seems dull, artificial, or like a stage where others are playing scripted roles. So it feels like a drama or a script or a skit or play. Some may even feel as if they are observing themselves from afar or as if they are diseased. A common complaint among these experiences is lack of emotions. The number of people who experience this disorder in a pure form or isolated form is limited. More often, this derealization and depersonalization occur alongside with other conditions like depression, phobias, and obsessive compulsive disorder. So commonly, these disorders, these symptoms are uh, part of the illness, and isolated people with only depersonalization and derealization are found to be rare. Elements of this syndrome can also be found in mentally healthy individuals, such as condition of exhaustion,
physical exhaustion, sensory deprivation, hallucinogen use, or during hypnagogic or hypnopompic states of sleep. The experiences of depersonalization and derealization are akin to near-death experience that happen during moments of extreme life-threatening conditions. So, in depersonalization and derealization, patient may describe some of these experiences or feeling as uh, they may say like this: I feel like I don't exist, lacking a true self. My mind seems clouded and if filled with cotton. I feel mechanical, almost like a robot. I know I have emotions, but I cannot connect with them. My thoughts seems foreign to me. It feels as if I am observing myself from a distance. I experience out of body sensations like a split of self. So these are the versions of depersonalization and what they may expect it to express in derealization is the world around me appears artificial and devoid of life. Now the person is talking about his surroundings. It is as if there is glass barrier separating me from everything else in the surrounding or environment. Object seems distorted, either too big or too small, but it is not Lilliputian hallucinations. And sounds are either too quiet or excessively loud. When we look upon the history of such a person, one may found that there is a history of childhood trauma, especially emotional abuse or neglect. Other contributing factors include exposure to domestic violence, being raised by a parent with severe mental illness, or the unexpected death or suicide of a family member or close friend. The average age when symptoms first appear is 16, with 95% of individuals showing signs before turning 25. Additionally, recreational drug use, particularly marijuana, ecstasy, and ketamine, is another recognized cause of this disorder. But in case of substance-induced this disorder, can be diagnosed only when the person is abstinent and devoid of substance use for a longer period of time and still experiencing these depersonalization or derealization, because this depersonalization and derealization can occur in influence of substance also. Differential diagnoses are major depressive disorder, obsessive compulsive disorder, dissociative identity disorder, dissociative amnesia, or any kind of conversion disorder, anxiety disorder and psychotic disorders, substance or medication induced disorders, mental disorder due to another medical conditions like temporal lobe epilepsy or partial and frontal lobe epilepsy. Suggested treatment for depersonalization and derealization disorder are psychotherapy such as cognitive behavior therapy, psychoanalysis, and psychiatric medications. However, these therapies is limited information on effectiveness, and recent research has not identified any clear evidence-based options of treatment, primarily due to shortage of randomized controlled trials. But in a study by Hunter and colleagues in 2005, conducted on 21 patients who underwent an average of 13 sessions of CBT, the result showed that there was decrease in dissociation, depersonalization, anxiety, and depression, with 29% no longer fitting the diagnostic criteria after treatment. Still, they had the residual symptoms. These improvements persisted over the next 6 months. So, in summary, neurasthenia refers to a syndrome characterized by chronic fatigue and distressing complaints of increased fatigue after mental effort or bodily weakness and exhaustion after minimal effort. It is commonly seen in medical settings and is often associated with symptoms of depression and anxiety. Depersonalization derealization syndrome, also known as depersonalization derealization disorder, is a mental health condition characterized by persistent or recurrent feeling of detachment from uh, oneself, known as depersonalization, and from one's surrounding is derealization. thank you. Thank you to all.